Hi, my name is Dane, and in today's video we'll be talking about blood transfusions, which will include the nurse's role. So, what is blood transfusion? It is as a nurse who will be transfusing blood into patients who is low on red blood cells. It is most commonly done through donated packed red blood cells. So, what causes a patient to be low on red blood cells? Number one is blood loss. They could have had major surgery or trauma, or they could be anemic, where the body does not produce enough red blood cells. They could have conditions that result in this, such as renal failures and cancers, to name just a few. So what is the importance of red blood cells? So the body needs red blood cells and its associated hemoglobin to carry oxygen from the lungs to the entire body, and then exchange it with carbon dioxide, and then exhale it through the lungs and back into the environment. Now, when is it to transfuse a patient with red blood cells? So recent guidelines say that transfusion occurs when hemoglobin levels falls down to 7 to 8 grams per deciliter. So what is a normal hemoglobin level? It depends. For males it is 14 to 18, and for female it is 12 to 16 grams per deciliter. Now let's look at the nurse's role when transfusing blood. Now, before transfusion even begins, there is a lot of prep work that is super important in order to prevent any blood transfusion reaction. Now, let's say, for example, our patient is ordered to be transfused with 2 units of packed red blood cells. First, they need to be typed and cross-matched. You or phlebotomist will draw up the patient's blood, and everything he needs to be done perfectly to avoid any clerical errors to prevent transfusion reactions. So special attention needs to be paid on patient's identifications and what is written on the blood band. And then the blood will be sent off to a lab, and the blood bank will match it to a donor blood, and they will prepare the amount that you order. It's also important to know our patient's ABO compatibility and their RH factor, to know what they can receive and what they can't receive. For example, if our patient is A negative, they cannot receive A positive blood because they will react to it. Next is informed consent. Here, it is also important to know their understanding of the procedure and to give patient education if needed. Also, it's important to ask them if there's any allergies or if they have history of blood transfusions before. Because if they have received, how many times have they received it? Because if they have received a lot, they could be at risk of febrile non-hemolytic reactions where the body develops antibodies for the blood transfusions. See, in this case, just let the doctor know they could be pre-medicated with antihistamines or paracetamol to prevent this. Now, next up is the cannula. 18 gauge or larger IV access is needed for red blood cells transfusions to avoid cell lysis, because if it lyses, there's no point in transfusing it to our patient. Special equipment is used to transfuse red blood cells. Here it shows the wide tubing with an inline filter to further filters the substances out as well. Now grab a bag of normal saline of 0.9% to prime and to flush the line with. Now here, you need to know that there's no other solutions compatible with blood transfusion. No medications and no other solutions such as dextrose is compatible at all. After you've done everything, pack the blood and the bag and dispose it in proper bin. Do not dispose it in a regular bin. Now, just before the transfusion time, there's a few more things. First of all, only transfuse 1 unit at a time, even if our patient requires 2 units. And that backup blood needs to stop within 20 to 30 minutes once it leaves the fridge and be finished by 2 to 4 hours maximum. Why is this? This is because once that blood leaves the fridge, it has the risk of developing bacteria, and then we can give our patient septicemia. Also, special device can be used to warm the blood if our patient requires a lot of blood transfusion and if they're at risk of hypothermic shock. Now, we have to verify and re-verify. Grab another nurse to do separate checks, and there are a few to go through. First of all, check the validity of the doctor's order, and then check the patient's identifications versus what the blood bank has, and then confirm our patient's blood type versus the donor blood type, checking the compatibility, the Rh factor as we mentioned before, and then check the expiration date of the blood pack, and then do a physical examination of the blood itself, see if there's any clot and if they have damage in any form. Now, everything must match perfectly. Even if there is a small discrepancy, we don't want to give it because it has a risk of transfusion reaction. Now, we want to do a set of baseline vital signs, making sure that our patient is within the normal limits, paying special attention to temperature. Because if our patient has a raised temperature, we don't want to give it either. Then we want to explain procedure again, and if our patient is alert and orientated, make sure that they know if any of the symptoms such as sweating, chills, chest pain, itchiness, shortness of breath occurs, to let us know, because it could be a form of transfusion reaction. And if it occurs, stop the transfusion immediately and do not flush. Okay, now it's finally time for transfusion. You have your blood ready, you check that our patient's IV access is patent, you have the blood ready through an infusion pump. You want to start the transfusion slowly. At first, at about 2 mL per minute for the first 15 minutes. Well, why is this? This is because we want to minimize the blood that is being transfused into our patient in case a transfusion reaction does occur. So we also want to stay with our patients for the first 15 minutes as well, looking at them, monitoring them, because this is when most reactions does occur. So we want to monitor vital signs throughout. We measure it at 5 minutes, and then at 15 minutes, if our patient is okay, we increase the rate to normal rate, and then we do another one at 30 minutes, and then hourly, as well as 1 hour post transfusion. Keep in mind that our transfusion has to be finished within 4 hours maximum from when it leaves the fridge, not when we start it. So, transfusion reaction is an umbrella term for a lot of reactions that our patients can have. First of all, they can have hemolytic reactions in which our patient's immune system is actually killing the donor blood because it is mistyped. Then they can have febrile non-hemolytic, which we talked about before. They can have allergies, including anaphylaxis. They can also have graft versus host disease, which is deadly but happens days later post transfusion. Now, we also want to monitor fluid overload as well for patients who are at risk, such as patients who have congestive heart failure and renal failure. Now, when you do actually notice an increase of 1 Celsius from baseline, we want to let the doctor know immediately, and we also want to monitor urine output. Are they putting low urine output, or are they putting no output at all? And then we also want to look at the urine itself. Is it purple? Because if it's purple, it can also indicate the free-floating hemoglobin from the red blood cells that have lyased as well. Alright, now let's talk about when a transfusion reaction does occur. First of all, stop the transfusion and do not flush. Then you want to notify the physician, the blood bank, as well as if the patient is having an anaphylactic reaction, push the emergency button. And you want to grab the RNs on the floor to help you as you want to stay with your patient, making sure that their respiratory is not compromised using the ABCDE systemic assessment. Now, depending on the types of reactions, the doctor can order medications such as corticosteroids, antihistamine to reduce the immune response, antipyretics to reduce the temperature rise, as well as adrenalines if they're having the anaphylactic reaction, as well as AIVT to help flush the hemoglobin out of the system. Now, lab studies are going to be done to see their clotting factors level. This is because most of the time we don't know what types of reaction they're having and the severity. Say for example, they're having a hemolytic reaction, they could be at risk of disseminated intravenous coagulation where clotting factors in their body are completely depleted and they can bleed out and die. Now, full blood examinations that look at electrolytes can also be ordered as well. Now, last but not least, we want to document everything. We want to document what happened, when it happened, what types of reactions we observed in our patient, and what action we took, as well as what the patients were given if they gave them anything. And then we also would document what lab studies were done and what blood were drawn up for, as well as, and most importantly, how our patient is currently doing. Now that wraps up blood transfusion procedure for nurse's role. Thank you so much for watching. Bye!